Hello everyone, we are going to talk about developmental dysplasia of the hip, and this talk will be focused mostly on prior to walking age. As we know, developmental dysplasia of the hip is a spectrum which includes everything from acetabular dysplasia, as you can see in the top picture, to subluxation to a frank dislocation. There's also instability, which is a dynamic phenomenon which we may not necessarily appreciate on radiographs, but can see on dynamic investigations such as an ultrasound. As we know, acetabular development happens from three primary sources. One is the acetabular anlaga, which is the cartilage around the acetabulum, and this is primarily responsible for the development of the acetabulum from 0 to 4 years of age. This can be affected if there is lateralization of the femoral head and there is not adequate stimulation of the acetabular cartilaginous anlaga. We also know that the triradiate cartilage contributes to acetabular growth up until 8 to 10 years of age, and this is primarily responsible for the width of the acetabulum. And then beyond that, as we hit the secondary growth spurt, the secondary centers of ossification contribute to approximately 25% of the weight-bearing portion of the acetabulum. And this then results in increase in acetabular depth, and it also determines the version. And this secondary center of ossification can be damaged if it is not appropriately loaded by the femoral head. So excessive loading from a lateralized femoral head can result in acetabular dysplasia. Looking at the epidemiology of DDH, we know that unstable hips at birth are extremely common. 5 to 20 out of 1,000 live births will have some degree of instability, and true DDH is seen in roughly 2 to 6 out of these 1,000 live births. Girls are far more affected than boys, and we do know that there is a small percentage of late dysplasia where there may not have been dysplasia noted on the initial evaluation. Since we don't have good denominators, it is very difficult to quantify this percentage. The left hip is affected more frequently than the right. There are some studies that suggest that if there is right hip involvement, then the deformities may be a little bit more severe and more difficult to care for. However, this has not been borne out in the larger studies. These kids clinically will present with either a hip click or asymmetric thigh folds or skin folds or frank instability, and this is usually picked up at the neonatal exam by the pediatricians, and these are the main reasons why they get sent over to us for further evaluation. In the United States, we do not practice universal screening, but we do practice risk factor-based screening, and therefore it is important to know what these risk factors are. The most common is going to be female gender with breech presentation at birth. That gives us the highest risk, which is almost 13%. Male breech and family history are almost as similar as far as risks go, and they're roughly about a 3% risk. Family history in itself in certain cohorts has been found to be approximately 6% when you have a sibling that is affected, 12% when you have a parent that is affected with DDH, and almost 36% when you have both a parent and a sibling that has DDH. So when we think of risk factors, remember the alphabet F. It's oftentimes firstborn, female, frank breech, positive family history. Those are the main risk factors, of which breech and family history are the most important. And there is a postnatal risk factor, which is improper swaddling with the legs extended and tightly bound together. So anytime you see DDH, look for torticollis in foot issues and vice versa. So if you have somebody with torticollis, always examine their hips. And so also with children with foot deformities, especially calcanevalgus feet, as you can see here. With clubfoot, there is not really a true association with DDH. So you may not necessarily need to screen children with clubfoot for DDH with an ultrasound, but certainly a good idea to examine them clinically. Here is an example of how to do the Ortolani maneuver. So you're stabilizing the pelvis with one hand, you grasp the thigh with the other hand, you have a finger right over the greater trochanter, you flex and adduct the thigh and give it a gentle posterior push and see how far that trochanter moves, and that gives you a sense of how stable or unstable the hip is. Whereas for the Ortolani maneuver, you flex and abduct the hip and you make a little lifting motion with the finger that's on the trochanter, and if you feel that clunk as you push it up, then that indicates a reducible dislocated hip. The sensitivity of these is relatively low, so maybe about 60% or so, but if you do see these, especially in the first 3 months, then the specificity is pretty high. So here is a video that illustrates the maneuver. So that's the Ortolani test. You can see me pulling up, and then that's the Barlow where you can see the hip coming out. And there's the limited abduction. There's me lifting it back in place again, and you have full reduction. So this is a hip that initially was out, which means dislocated, and then goes back in, which is a Ortolani positive dislocated hip. The coronal view, which is the view on the top image here, and that's the corresponding ultrasound view, is similar to an AP pelvis laid on the side. And what you see is the femoral head covered by the acetabulum and the labrum. So there's the acetabular anlaga cartilage and then the labrum. Then you can see the capsule. You can see the hip abductors coming down to the greater trochanter. You can see the triradiate cartilage at the base, and then you see the ischium down below. The transverse view is like a transverse cut on a CT or an MR. So what you see again is the femoral head and the troch, femoral head and the troch. You see the metaphysis, and since the metaphysis blocks out most of the anterior pubic bone, you don't really see much of that because of what we call acoustic shadowing, with the sound beams bouncing off the bony metaphysis. You can still visualize the triradiate cartilage quite nicely, as well as the ischium in the back and the posterior labrum. So what you want to see is the head sitting right up against the triradiate without it having echogenic material in between, which would indicate a subluxation. Similarly, in the coronal neutral view, you want the head again to be sitting right up against the triradiate without any white or echogenic material in between the head and the triradiate. If you draw a line down the ilium, it should intersect at least 50% of the head, and that should be deeper to that, which means that is more than 50% of the head inside the acetabulum. 50 to 59 degrees of an alpha angle. The two Bs are the ones that haven't matured by 3 months, so they're still shallow. So again, 50 to 59 beyond the 3 months of age. The two Cs are even shallower, so 43 to 49 degrees of an alpha angle with the hip still appropriately reduced. And then there is the type D, which is the decentered hip, which means the hip is not seated up against the triradiate cartilage. Type 3s are horizontal dislocations, and type 4s are dislocations with the labrum interposed in between. This means that there is room to be able to watch them and not jump in to treat them right off the bat and minimize overtreatment of these hips. So here is an example of neonatal instability. This is a baby seen close to birth. You can see that there is some echogenic material in between the triradiate and the femoral head on the coronal flexion views. On the coronal adduction view, there's a little bit more separation here. Same thing on the transverse flexion and adduction view. You can see a little bit of separation in between the triradiate and the femoral head. And at 6 weeks of age, you can see now that the hip is seated beautifully against the triradiate, more than 50% covered, and on flexion on both the transverse and the coronal views, there is no separation at all, indicating resolution of the previously noted instability. So the next question that comes up is with follow-up imaging. And the two important high-risk groups are the breech babies and those with family history, and the follow-up strategies are slightly different for these. So when we have a breech baby who's had a normal ultrasound and exam at 6 weeks of age, we still do need to follow them because approximately 30% of them will have dysplasia at 6 months of age, and about 10% of them will have dysplasia when they're imaged at a year or slightly beyond. On the other hand, babies with a normal exam and ultrasound at 6 weeks of age but have a positive family history, when we look at them in the long term, they do not seem to have any increased dysplasia, so they do not necessarily need any additional follow-up. Looking at the natural history of untreated DDH, we know that for frank dislocations, for a unilateral dislocation, there's going to be leg-length discrepancy, and it can lead to ipsilateral knee deformities, limb length discrepancy, scoliosis, and gait abnormalities. If the dislocations are bilateral, then oftentimes they end up with lumbar hypolordosis and then increase in low back pain down the road. These are the easy ones. The ones that are harder to pick up are the ones that have just the shallow acetabuli or some subluxation. And based on natural history studies, again, we know that a hip that reaches skeletal maturity with some degree of dysplasia and subluxation will do very poorly. And even the ones that are just dysplastic without the subluxation with a center edge angle of less than 15 to 20 degrees, the risk of osteoarthritis increases in those significantly. So when we look at these hips early on, the question then becomes, when do we transition to radiographs? And the board answer for that is 4 to 6 months of age. With radiographs, one must be cognizant of the fact that these are oftentimes non-orthogonal and dependent on position. And early on, the femoral head is not ossified, hence the ultrasound is much more useful. It's also dynamic, so that also helps with decision making. However, once you transition to radiographs, even if the femoral head is not ossified, you still need to know how to classify these hips. So the International Hip Dysplasia Institute came up with this classification where they mark out the midpoint of the metaphysis, and that should be in the inferomedial quadrant formed by the horizontal Hilgenreiner line and the vertical Perkins line. So if it's in the inferomedial quadrant, that is an IHDI grade 1, which is normal. The inferolateral quadrant is divided into two equal 45-degree arcs. And if that midpoint or the H point is lateral to the Perkins line, but within the first 45-degree arc, then that's an IHDI grade 2. If it's beyond that, but below the Hilgenreiner line, that's a grade 3. And if it's above the Hilgenreiner line, that is a grade 4 dislocation. Once we've made the determination of a diagnosis of either a subluxated or a dislocated hip or an unstable hip that needs treatment, we typically tend to put them in the Pavlik harness. The Pavlik harness is the most commonly used brace in the treatment of infant DDH, and it consists of a chest strap with shoulder straps. So this helps determine where the chest strap needs to be. And then you have the leg portion with an anteromedial and a posterolateral strap. The anteromedial strap helps with hip flexion. The posterolateral strap is to adjust the degree of internal rotation and abduction. Typically, we do not overly tighten that posterolateral strap because then it does not allow for the 30 to 40 degrees of free adduction that you need to minimize the risk of ADN. We also avoid excessively tightening the anterior strap because excessive flexion can result in a femoral nerve palsy. Typically, these happen within the first week or two of application of the Pavlik harness, and that's why it's very important to tell the family to look out for active knee extension within the harness, and it may even be worth having a phone call in about a week or so just to make sure that the baby is actually actively kicking on both sides. With the Pavlik harness, we typically use ultrasound in addition to a clinical evaluation to monitor how well things are proceeding. And the frequency of monitoring is related to how bad the hip dysplasia is. So for a dislocated hip, oftentimes we'll bring them back weekly. For a subluxated or an unstable hip, or a dislocated hip, once it's reduced, we typically tend to follow them up in 2 to 3 weeks. We know, looking at the Pavlik harness, that the risk factors for failure are mostly a hip that is completely dislocated and irreducible. So that's the DI, as in dislocated irreducible hip, also known as a graph 4 hip. Late age, and age 7 weeks seems to be a common refrain in multiple studies. Sometimes the right hip, as mentioned previously, may be at slightly higher risk. Use of a static brace, as in not a Pavlik, but more of a rhino abduction brace or a regular abduction brace. Kids with a femoral nerve palsy are at risk for failing treatment with non-operative means. There are other braces, as you can see in the picture down here. There are several other types of braces. The Ilfeld brace is something that's preferred at CHOP. We prefer to go to the tubing in brace after, and then you also have the rhino. So there are several other braces that are available in case the Pavlik does not work. So just to recap, as far as treatment is concerned, clinically evaluate, get an ultrasound. The ultrasound helps us with position, stability, and morphology. So where is the hip at rest? Is it located? Is it subluxated? Or is it dislocated? What happens with stress? Does it remain stable, or is it loose, or is it dislocatable? And then what is the acetabular morphology like? If it's a normal acetabulum or a dysplastic acetabulum, if there's laxity, is it more than the 3 to 4 millimeters that we normally would expect up to 6 to 8 weeks of age? Or is it within that physiologic range? So those are the determining factors as far as the treatment of these hips is concerned. The biggest line in the sand, though, is the hip dislocated at rest? This is important because if the hip is dislocated, there is no waiting. Then you treat them as soon as you see them on day 1. For dislocated hips, irrespective of whether they're reducible or irreducible, we try a Pavlik harness and we bring them back in weekly until the hip reduces or 3 to 4 weeks have passed. That is what we would call a trial of Pavlik harness. If there is no progress, then we abandon the harness and move on to something else. However, if the hip is in and loose or dislocatable, then we can wait the 6 to 8 weeks to treat them, and the treatment remains the Pavlik harness. Now, with the Pavlik harness, the difference in frequency and monitoring, as we discussed, is you bring them back in every 2 to 3 weeks for hips that are already reduced. A hip that has been dislocated and you put them in a Pavlik and they reduce. Once they reduce, they can go back to this Q 2 to 3 week schedule. So here is an example of a successful use of the harness. So here you can see at presentation, the right hip is dislocated. There's the ilium, the hip is barely touching it. And same thing on the left hip, it is unstable. At week 1, you can see some progress. The labrum is no longer interposed there. You can see the hip coming down, and same thing on the left side. At 2 weeks, things are even better. Now the hips are both reduced, though the acetabulae are significantly dysplastic. So at this point, given the fact that the hips have now reduced, we move on to the Q2 to 3 week schedule. So here we are at 5 weeks. Again, improving acetabular morphology and good stability. Not quite normal yet, so they still remain in the harness. Bring them back at 8 weeks. Now your line down the ilium is covering more than 50% of the head, and the alpha angle is maturing nicely as well. So that's when we can afford to start getting them out of the harness. Now the next step may be a different kind of brace, which is oftentimes what people move to. And if that fails also, then you end up with a closed or an open reduction. When you look at the two types of Pavlik failure as described by Suzuki, one is failure of reduction and the other one is failure of stabilization. The ones that have failure of stabilization are much more likely to do well with a more rigid brace compared to the ones that fail to reduce completely. Now, once you've attempted the Pavlik and then potentially gone to an abduction brace and that hasn't worked as well and the hip is still dislocated, then the next step is to take the child to the operating room, do an arthrogram to assess the structures that are inhibiting or impeding reduction, and then attempting a closed reduction, which is basically a Barlow maneuver under anesthesia. I'm sorry, an Ortolani maneuver under anesthesia, and then placing the child within a hip spica cast to keep the hip in reduced position within what is described by Paul Ramsey as the safe zone. So the safe zone is the range of motion of the hip in between maximum abduction, and you start adducting the hip till the point it pops out, and that gives you your safe zone. So if you can put the hip within that safe zone, then it can stay in the harness without dislocating. Or if there's too much abduction, then remember we get ADN. So we don't want redislocation and we don't want ADN. So sometimes if that safe zone is too narrow, what one could do is perform an adductor tenotomy, and that increases the amount of abduction that the child has, and that widens the safe zone and gives you a little bit more comfort in being able to put the hip in a spica within that. And then obviously continue to monitor them, because there will still be a small percentage that will need subsequent intervention for residual acetabular dysplasia. Let us look at an example of an 8-month-old with a dislocated right hip, as you can see on this intraoperative image, where we attempted a closed reduction, and you can see after a closed reduction the femoral head does point towards the triradiate, but the labrum is not draped nicely over top of the femoral head like a nice fine rose thorn. And then when you get cross-sectional imaging after the closed reduction in the spica cast, you can see that the right hip is dislocated posteriorly. So this is not an acceptable closed reduction. On the other side, you can see a nice smooth arc in between the anterior femoral neck and the pubis, suggestive of an appropriately located hip. And this is similar to the Shenton's arc or the Shenton's line that we see on plain films on the AP view. So we then ended up taking this child back to the operating room for another closed reduction, which was then successful. So what are the things that can be impediments to closed reduction? You can have extra-articular problems such as tight pelvifemoral muscles, namely the iliopsoas and the adductor longus. Or you can have intra-articular issues such as a tight or an hourglass capsule with a constriction from the psoas on top of the capsule, thickened ligamentum teres, a labrum that is flipped into the joint and is impeding the head from going back in, a very tight transverse acetabular ligament in the inferior capsule, which frequently is the main culprit, or fibrofatty tissue that is sitting inside the acetabulum and blocking the head from going back in, which is what we call the pulvinar. When you look at the biggest risk factor for a failed closed reduction, it is a tonus type 4 hip, which about 10 to 15% of the time may end up redislocating after a closed reduction. And this also is a risk factor for AVN after closed reductions. Now, what do we do when a closed reduction does not work, or if it works and the hip redislocates? The option at that point is to do an open reduction, and this may be done either via a medial approach or an anterior approach, and the choice is somewhat surgeon dependent based on their training and the comfort that they have with either approach. The medial approach typically is done prior to walking age because you don't want the capsule to be too far stretched out, since you cannot do a capsulorrhaphy with this approach. But you can use the ligamentum teres as a tenodesis when you tack it down to that inferior capsule, and that can help decrease potentially the risk of redislocation. Medial approaches can be done either using the Ludloff approach, which is in between the adductor longus and brevis and then the adductor magnus posteriorly, or the Ferguson approach, which is in between the pectineus and the adductor longus and brevis, or the popular Weinstein approach, which goes in between the neurovascular bundle and the pectineus and takes you down to the hip joint. The structure at risk with any of these is the medial circumflex femoral vessel, and damage to that can potentially lead to avascular change. However, looking at the rates of avascular necrosis, more recent studies have shown that the rates are equivalent in an anterior or a medial approach. And previously, we used to think that we had to wait for the ossific nucleus to develop before we do an open approach to the hip. However, the data does not seem to support this, and you do not necessarily need to wait. The other approach, which is quite popular, is the anterior approach, which uses a Somerville or a bikini type incision just below and parallel to the iliac crest. You find the Smith-Peterson interval, as you can see with the scissors being pointed out here, in between the sartorius and the tensor fascia lata laterally. Once you open up that interval, you come down into the depth of the interval where you find the rectus femoris arising from the anterior inferior iliac spine. So here you can see the rectus femoris nicely outlined with the hemostat. This is taken down after placing a stay stitch through it for later reattachment. And then you dissect medial to the rectus and identify the iliopsoas coming off the inner table. We extraperiosteally dissect on the undersurface of the psoas, lifting it off the inner table, and then identify the tendon of the iliopsoas. We see the red muscle going into the white tendon to confirm that it is the tendon, and you can further confirm this using a nerve stimulator if there's any question. And then we do an intramuscular lengthening of the iliopsoas by cutting just the tendinous portion at the pelvic brim. This results in adequate release of the psoas up at the level of the pelvic brim. Once that is done, you complete the capsular exposure and then move on to the next step. Once adequate capsular exposure has been obtained, then we make a T-shaped capsulotomy with the horizontal limb of the T being just distal to the acetabular margin that is palpable, roughly about 3 to 5 millimeters away, so as to minimize damage to the labrum. And then we make a longitudinal cut in the capsule, typically closer to the mid-neck portion. However, when the hip is high and lateral, one wants to keep that cut a little bit more medial so you have enough of a lateral leaf to bring over for a capsulorrhaphy. Once the capsule is opened, we see the ligamentum teres and follow it all the way down into the true acetabulum, clear the pulvinar from the true acetabulum, excise the ligamentum teres if it is too thick, and then follow it all the way down to the transverse acetabular ligament, which is then released along with a portion of the inferior capsule. This is an extremely important step of the anterior open reduction, because if we do not clear the acetabulum well and do a proper release of the transverse acetabular ligament, the head will not go down deep enough into the acetabulum. Then we take the lateral leaf of the capsule, as you can see outlined on this picture here, and bring that over to the periosteum at the base of the superior ramus, and then suture it there, and that then takes the slack out of the capsule and helps us bring the head closer to the acetabulum, and this is what is the internal rotation capsulorrhaphy. And then you can bring the inferomedial leaf and then suture it back to the lateral leaf of the capsule. You can do this either very simply, as I've illustrated there, or you can make a series of more complex cuts that fit beautifully into each other. Once that capsulorrhaphy is done, the hip should be very stable in almost full extension and minimal abduction. And then we can close the tissues over top. Now, traditionally, once you have done an open reduction, this is the position of immobilization, as you can see on the last picture here, with the hip flexed to about 30 to 40 degrees, abducted about 20 degrees or so. This is to allow for proper ability to fit them into a car seat and also to allow for hygiene. Also, another point to make here is, as you've seen through these series of images, we have not split the iliac apophysis in this case. Traditionally, the iliac apophysis is split, which gives you wide exposure of the acetabulum. However, as you can see here, it is possible to perform an open reduction without necessarily splitting the iliac apophysis, but this should be reserved for the more experienced amongst us. Now, for the older child, as in a child more than 18 months of age, we've lost a significant amount of acetabular growth and remodeling potential. So oftentimes what we will do is, for someone who presents beyond 18 months of age, we will perform an open reduction and then try and catch up the acetabular growth with a pelvic osteotomy. And there are studies that show that this may be a very good strategy for the older child. AVN, though, remains a challenge. Now, how do you assess what kind of osteotomy you need? So if once you've done your open reduction, the hip is in neutral position and it's stable, then we don't really need anything else. If we need to abduct and internally rotate the hip to get more stability, then they would be better off with AVDRO. If they're more stable in flexion, then we are better off with a pelvic osteotomy. And if they need both flexion and abduction and internal rotation, then you need to do both a femoral and a pelvic sided procedure. And this is based off of the experience of Tony Catterall and has been described in a paper in the British JBJS. So even though the hip did quite well early on, once she hit her adolescent growth spurt, she ended up with some degree of residual dysplasia and had to undergo the pelvic osteotomy or the periacetabular osteotomy. quick word on AVN, or proximal femoral growth disturbance. This has been classified by Kalamchi and McEwen here at our institution as type 1, where there's only a small delay in ossification. Type 2 is where there is a growth disturbance mostly in the lateral portion of the head, and the head tips into valgus. So this is what we call caput valgum, and the valgus is through the head-neck junction. There oftentimes is some degree of either anterior or posterior tilt of the head at the same time. Type 3 growth disturbance is when there's a central insult and you end up with a very short neck and a high-riding trochanter. And type 4 is when the whole femoral head is involved and you end up with an irregular, poorly growing femoral head with a short neck. So there are different interventions for each of these based on what the individual pathoanatomy is. Looking at residual dysplasia, there are multiple different osteotomies that have been described for addressing residual dysplasia after a closed or an open reduction. So looking at the options that we have for pelvic osteotomies, there are two main classes of pelvic osteotomies: the reconstructive pelvic osteotomies that cover the femoral head with hyaline cartilage, or the salvage procedures which cover the head with fibrocartilage, which does not last quite as well in the long term. Within the reconstructive osteotomies, we either have redirectional osteotomies or the volume altering or reshaping osteotomies. For the redirectional osteotomies, the femoral head needs to be concentrically reduced within the acetabulum, and then and only then can you rotate the acetabulum over without creating impingement. The most commonly done redirectional osteotomies are the Salter osteotomy, usually up until age 6, or once the child gets older, then you end up with a triple innominate osteotomy where you cut the ilium, the ischium, and the pubis, and then that frees up the acetabulum to be rotated around the femoral head. Once you hit skeletal maturity, then the Bernese or the Gans VA or periacetabular osteotomy is probably the most popular at this point to obtain better femoral head coverage. Reshaping osteotomies are when there is a mismatch in between the acetabulum and the femoral head. So typically, if the acetabulum is more capacious, then you can alter the volume of the acetabulum by doing an incomplete osteotomy and hinging down on the triradiate cartilage and making the femoral head and the acetabulum more concentric. Salvage procedures are either the Shelf or the Chiari osteotomies, and they cover the head with fibrocartilage. These are typically not commonly used unless the hip is beyond what can be helped with a reconstructive procedure. So looking at residual dysplasia, either the hip is concentrically reduced or it's not. If it's not, if it can be made concentrically reduced, then we look at whether the triradiate is open or closed. If it's open and the volume matches, then you end up with a Salter or a triple. If there is a mismatch for a capacious acetabulum, then you end up with a Dega or a San Diego type procedure. For closed triradiate cartilages, oftentimes you end up with a PAO or a triple. For hips that are non-concentric and cannot be made concentric is where we end up using salvage procedures such as the Chiari or the Shelf. So in summary, we know that DDH is a spectrum of involvement, and the high-risk groups include patients with breech presentation in the 3rd trimester or a family history, and we do need to examine these more carefully, use ultrasound as an adjunct to the clinical evaluation, and also to help us monitor our treatment success. It is very important for us to follow these hips long term because many of them will need additional intervention down the road, even unto skeletal maturity. And for best results, early diagnosis and treatment are the key. So For DDH, the bottom line is pick them up early, treat them early, best results with a Pavlik or non-operative management. And the later you pick them up or the later you treat them, the more involved the treatments get and the higher the likelihood of complications and arthritis gets. Thank you.